Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high-risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today's guest is Dewey Lloy. Dewey Lloy was dedicated for more than 40 years to the field of medical ultrasound, shaping both patient care and advancement of imaging practices throughout New England. He began his career in 1985 at a 230-bed community hospital in South Central Maine, where he gained extensive experience across all areas of diagnostic sonography, including general, obstetric, breast, pediatric, vascular, and echocardiography. By 1990, Dewey transitioned into leadership, managing ultrasound departments while continuing to practice as a highly skilled sonographer. Over the course of his career, he has worked primarily in Maine, while also contributing his expertise in Massachusetts and New Hampshire, cultivating a reputation for both clinical excellence and departmental leadership. Today, Dewey serves as the manager of the largest vascular laboratory in the state of Maine, supporting the work of 11 vascular surgeons and a multidisciplinary team. In this role, he remains deeply engaged in advanced vascular imaging practices, integrating innovative technologies and ensuring the highest standard of quality and accreditation. His long-standing commitment to patient-centered care, education, and innovation has left a lasting impact on vascular and diagnostic imaging services across the region. Please help me welcome Dewey Lloy. Dewey, thank you for joining us today. Our topic today is talking about new and old vascular. So thank you for bringing your expertise to us today and telling us about how we've progressed over the course of your career. Tell us a little bit about yourself to start with.
First off, Debbie, thank you for having me. Well, I have been doing ultrasound for approximately 40 years. So I am an RDMS, RVT, RDCS. So I pretty much have done the vast majority of ultrasound that can be done in our field. But I did start out in vascular quite early on, back in the mid 80s. And it was, there was much that was a lot different than today. But yet there's still some things that have really stood the test of time. And one of those being, the non-invasive vascular testing.
How did you get into ultrasound before we start off? How did you, because years ago, there weren't schools, right?
That's right. So
I trained on the job. So did you?
That's right. I trained on the job. I trained at a kind of a small, in Maine, it would have been considered a medium-sized hospital in kind of southern central Maine. And yes, at that time, there were not many schools around. I think the nearest one might have been Philadelphia back at that time frame. And so most of the folks I knew back then, that's how we did it. We trained on the job. But ultrasound was a lot different back then. We may have had, I don't know, 10 to 12 different kinds of exams that we were doing. We had an articulated arm scanner, and then we had just purchased the Diagnostics. And so we started real-time ultrasound, and that was pretty exciting.
Yeah.
So, so that was kind of the way I started, learning on the job and studying for the boards,
Wow,
going to any conference I could go to and
yeah,
taking it from there.
awesome. Well, it's amazing that I've made it this far in my career, a little over 20-ish, somewhere in there years. And when you make it to this point, I think you and I can look back and think, wow, we really have changed, right? As a profession. And so, talk to me about the early non-invasive testing that really has kind of stood the test of time that you were mentioning earlier.
Folks that do vascular all relate. It's just like the segmental pressure ABI testing, ankle brachial indices. I mean, it's still a staple of what vascular surgeons and physicians out there when they want to get kind of some testing to assess peripheral vascular disease, peripheral arterial disease. And yeah, we were doing a little bit differently back then, but essentially the core of the exam has stayed the same. And I work in the largest vascular lab in the state of Maine right now, and we're doing a lot of those tests currently. And it is a great benefit to most of our patients. And it's done in conjunction now with more of the advanced things that are being done. The Duplex, peripheral arterial duplex, grafts, and all of the complex peripheral arterial stuff would still it gives us a good overview of the vascular circulation, so the arterial circulation. So it's pretty remarkable that things can stand the test of time like that.
Yeah. Yeah, that is a foundational tool that just has never gone away, despite how advanced our technology is and what more we still fall back to that as a quick go-to, I think.
Yeah.
So yeah, go ahead.
Well, I mean, just as we look back and kind of how things evolved with vascular, I just wanted to touch on when I started doing vascular. I did a lot of general stuff, but when I started doing vascular, the way a lot of folks learned, you would go to a site. So ATL at the time was offering training, and I went out to Seattle, University of Washington, in conjunction with ATL, was offering a week-long training. And got to, at the time, I didn't really think much about it, but I got to train with Dr. Eugene Zerler and Eugene Strandis, and so they became now kind of iconic figures in the field of vascular. But we had no color Doppler when we started out, and today I guess we still have that fundamental of just doing a vascular exam without color, but nobody typically does because color is such a useful tool. And so when I look back at some of my first carotid ultrasound exams, and it would take me a long period of time. And now today, with all the technology that we have, we're much more efficient, but we're incredibly accurate. And so that was another turning point, I think, in vascular and how we evolved. We kind of came out of but we didn't know what we didn't have. So we didn't have color Doppler.
Right.
So we're perfectly fine. And in fact, today I'll still have a student occasionally do an entire carotid without color on, because I think we were really good at getting to Doppler. And pulse wave Doppler is really, I think, a very sensitive tool. And I think it can make you a better vascular technologist if you can get comfortable, if you only have that tool. So, and we did that as time evolved with a lot of different other vascular exams where we had to just rely on other things that didn't give us the color and the picture that we have today. So it is kind of good. You can't live in the past, but it's kind of good to touch it a little bit and figure, it can help you hone your skills, I think.
Yeah. Yeah. I think when I was in school, they were so excited because we had just gotten color Doppler maybe a year or two before, maybe 5 years before. And all the things, they used to do blind, right? Dropping a Doppler down into a baby's head, and just listening for the signal that they're trying to find, right?
Right.
And so that in and of itself is a skill, right? That thank God we don't need anymore. But for transcranial Dopplers, right? I hear so many people who have had to adjust the depth until they could find or hear, and so
Right.
really tuned. It was really a skill to be able to hear and adjust according to where you were at. But
Right.
yeah, just being more specific where you put the Doppler, the pulse wave, because now you can see it, right? You can see where the color flow is and the mapping.
Right.
And now, yeah, I don't want to get too far ahead of where color has gone, but
Right.
yeah, I certainly am grateful that I came into the profession with already having color. But I do remember when Cine came out, so I was extremely grateful for that when learning OB, because we didn't always used to have Cine either. So
That's right.
yeah,
That's why the freeze button got worn out on the machine, because I was
right.
constantly freezing and unfreezing to try to capture them.
Yeah, they'd have to replace that often.
Right.
So you use it more now for the color Doppler and transcranial, renal Doppler transplants or liver transplants and bypass grafting and surveillance, which I think is huge, right? Especially when you're able to see.
Oh yeah, yeah. I mean, it's about the anatomy. I mean, and it was about the anatomy, before we had color. And I did do transcranial Doppler where we would step it in, and we knew where the middle cerebral lived, and we had to find it. And in a lot of ways, I think that the pulse wave was incredibly sensitive, and it helped us. And then we learned with in relationship to the anatomy to angle and get what we needed. But yeah, when the evolution of color came along for transcranial Doppler, I remember it was an older machine. It wasn't color like we have today, but it helped. It was helpful to be able to visualize. So yeah, I think into now as colors evolve. I mean, real transplants, absolutely. And there's certain pathologies that now color can help us try to diagnose with hyperemia and or avascular situations. So yeah, no, I would not want to do a lot of vascular testing now without color.
Yeah. Have
Um,
you, so tell us about carotids and venous then, how that was helpful and before and after.
yeah, I mean, I think in terms of carotids, I was a huge fan of no color, quite honestly. But as it come along, I think it helped to improve the ability to just get through the anatomy. It certainly help you to try to sort of, if there's a stenosis, you see aliasing. It's going to help you to find the pathology quicker, because we used to have to kind of track the pulse wave cursor along and try to go through an internal carotid and try to find the peak velocities. We still have to do that, but I think that is good practice and it's good to do in general. But the color, really helps a lot with that. And for venous testing, and venous reflux, we use the color and it helps us a lot with finding perforators, analyzing some of the branches off, the profunda and that sort of thing. Whereas back in the earlier days, we didn't have the color and we just relied primarily on the compressions, which still today, I think, is a big component to the examination. But those were really the two big exams that we were doing in the early stages. I mean, we were doing non-invasive vascular testing and then carotids and veins, renal arterial studies without color. They were being done, but it was hard. Certainly visceral vascular, some
They're
degree of
hard
it.
with color, you know.
Much better with a color now. Yeah. Yeah. So we've come a long way, and it really accelerated once we got, I think, into the 90s and in the 2000 range. We started seeing, the ultrasound technology improve, and a lot of it, I think, was internal to the machine, where we would see images just improving, and how the digital beamforming came along, and then now we're all completely, the inside of an ultrasound machine is basically just a few chips. But yet the image quality is astonishing now, in terms of all of it, the V mode images, the color Doppler, the pulse wave Doppler. I mean, and the things that we can do with it today, it's just phenomenal. And doing that through that period of time, the 90s into the 2000s, I think we saw a very big increase in the numbers of exams we could do, the amount of pathology that we could see. It was phenomenal. I mean, in terms of bypass grafts, we were seeing a lot of things happening. Dialysis fistulas, many things came to bear relative to where we were 10 years prior to that. So there was I think, it was maybe the biggest chunk of growth that I saw in the entire time period over my career. So that was quite an exciting time. I remember we bought a machine one time that they said would take us into the next millennium, and I think we barely got it unpacked, and it was already replaced. So there was a lot of rapid growth in the ultrasound world back through that time period.
Yeah. Yeah, I think that's the time when they started using it for interventional radiology at different times, using it for a lot of even like help me with the word I'm looking for.
Yeah, no, I mean, in terms of
like
intervention,
surgical procedures, right?
Yeah, we started going into the OR more.
And I know going to
the
interventional was a new thing, a new field that was being developed, that ultrasound would go into to help with catheter replacement, ablations, different things like that, where we really kind of spread our wings into a lot of new and different modalities in this era as well, right? Not just increasing better resolution, but
well, I think I think I've always been a huge fan of ultrasound in terms of all the interventions, because even back in the 80s and into the 90s, we were doing a lot of biopsies. Everybody thinks of the first intervention in ultrasound is the amniocentesis, and I can't believe when we first got the real-time machine, the doctors were so comfortable with the old articulated arm, they still wanted to do an amnio on the articulated arm because they liked the little centimeter dots that went through the image. That changed, I think, pretty quickly, because real time was a wonderful thing, because we could actually see the baby moving around and that sort of thing.
Right.
Which is a good thing.
Very good thing.
But back then, I mean, I still remember doing pancreatic biopsies and drainages and that sort of thing. And I worked with one of the first transrectal prostate ultrasound machines that was purchased in the state of Maine. And that was in the 80s. And, that's another one. It really, today a prostate biopsy, there's many more passes. We started out trying to find the lesion and biopsy it specifically. And then we went to a 4-quadrant. And now I think they're doing like 16 passes for a prostate biopsy. So that intervention stuff was happening then. But today, I mean, we can help with drainages, percutaneous drainages. We're doing a lot of that type of intervention, paracentesis, thoracentesis, all
Right.
that kind of stuff. So it really has plumed because I think people found out, what ultrasound can do. And then now I think the point of care ultrasound, that's a huge, that has grown in a big way from what I understand. And I know we see it in the hospitals and we see it.
Right.
Our surgeons here, we used to get called in all the time to help them. And now they run the machine themselves. The OR, I think, at our hospital, our local hospital, they have, more than one machine. They have several, and doctors are getting more and more comfortable with using them. And so I think, in terms of intervention, I think ultrasound, it was there, but it needed skilled folks to run it, but now it's evolved more to the point of care. Doctors are using it. But yet, I remember, the first vascular case I went on was a carotid endarterectomy, and they, looking for intimal flaps post carotid endarterectomy, and now they don't call us in for that really anymore. They do it themselves, and then that we'll maybe get into it a little bit more later. But the whole carotid intervention has changed these days to the modern era. Here we have hybrid type procedures where they're doing TCARs, which is the transcarotid arterial revascularization. They can reverse the flow in the carotid and filter that blood, put in a stent. It's great for patients that have, risk factors that would preclude them from having a standard carotid endarterectomy, which is really the gold standard still. But those types of procedures, they all started way back, but today it's amazing where we've come. And the only thing is we really don't know where we're going to go. I mean, I think that is probably exciting if we could. No.
Right. Yeah. And then I think you were also talking to me about this limb flow procedure that I'm not familiar with at all.
Okay.
But it sounded so fascinating because I told you the story of me not liking vascular with a patient losing a toe while I was doing an arterial, and I thought I was just gonna fall out right there in the room. I got to the foot to do arterials and I
Yeah.
didn't the toe, and it fell off and went under the bed, and we had to retrieve it and put it in a bag, and oh my God.
Well, at least you came back the next day. I mean, that's,
Yeah. Oh gosh.
yeah, I mean, that's,
Quite an experience. But
yeah.
this is why I'm glad to hear about this procedure, because I'm hoping that I was pretty traumatized by that.
Yeah.
I
Yeah.
think there was a big
Well,
decision about my future in vascular made on that day. And unfortunately, it was very early in my career of vascular. So
well, I hope I'm going to say some stuff that may encourage some people to want to get into the vascular field, because I
yeah.
think it's a challenging but yet rewarding branch of our ultrasound tree. And so, yes, the need to evaluate for wounds and distal ischemia associated with, a lot of times it's diabetic patients or people that have really pretty bad small vessel peripheral vascular disease that's causing them to have issues with their toes, their foot. And there is a new procedure that I've been fairly involved with, and we've been doing some of the cases here for about a year now, and it's called limb flow. And what it is, it's a transcatheter arterialization for the veins in the foot. So what it's essentially doing is it's converting the veins in your foot to becoming an artery. And so far, the studies it's showing to be about 60 to 70% successful. And for what it really is there are three stents that are placed, one from above, typically in an artery proximal to the disease that has reasonably good flow, and then another stent that's being placed from below. They'll go in. Typically, the most common is the lateral plantar vein, um, which is actually not many people understand the venous anatomy of the foot. But once you get to know it, it's a pretty prominent vein, and it connects to the deep venous system. And it will go from basically the posterior tibial vein becomes the lateral plantar vein. And so they will put a guide wire up and put a stent up from below. And then there's a third stent, which is a crossing stent that will be connected from the more proximal stent to the distal stent. And they have a special tool that the manufacturers make that help them to make that connection. And it's amazing when it works really well. It takes, sometimes we see some things improve immediately, and then sometimes it takes a little while. But we can take, for example, we'll still do toe brachial indices and PPGs on the toe, and we can have some patients that literally got no detectable flow in the toes. And it will improve it relatively soon. And we've had people that have gone from being in a wheelchair to being up walking around. Situations like you saw early on where the feet or the toes look really pretty bad and they get a lot better. And it's quite rewarding, when you'll see people. In fact, we had a patient that was wheelchair bound, and he even in his later years liked to play hockey, and he got to the point he couldn't. He had limb flow done, and he's talking about getting back out on the ice. So that's pretty remarkable, quite honestly.
Yeah, that's amazing.
So I think it shows a lot of promise. And even for the folks that it fails, and there are, and it does happen. They occlude or something, and when that occurs, it's still not awful, because the neovascularity that occurs from just the stenting, even for a period of time, it's phenomenal. I had a patient that had all three arteries going down to the feet occluded. So the peroneal, the posterior tibial, and the anterior tibial arteries all occluded. And they had the lymph flow. Things were going along reasonably well. And then for whatever reason, it went down. And, but I did a non-invasive test. TBI was looking reasonably good. So then I duplexed it. The anterior tibial had been opened up, and it was getting amazing flow through it. So there can be improvement even in failure with the lymph flow. And so I think it's quite exciting. And the fact that we can, it makes a lot of sense when you think about it. Your arteries aren't working good, they're plugged up, or they're just got tons of disease in them. You got the veins right there. If you can connect into them and convert them, it makes a lot of sense. And it does work. And the successes have been great. And even the failures, I think, have shown some promise to help.
Promise to help. Yeah. That's amazing. That's amazing. I love that. I love that. I think diabetics will be glad to hear things like that. And it can only get better. I just think,
Right.
wow, we've come so far, and yet we still have, as things get better, we learn new things and new applications to things. And so it's exciting to hear. And it's hard to keep up with it all, right? Like, unless you're in the field. I guess if you're in the field, it's a lot easier to keep up with, but it's exciting. And that's, I think, what keeps us in the field for as long as we are, is because things do change and they do improve. And we do see that over the course of time. And more is required of us, right? And more understanding and more education. And so I think that's one of the reasons why I'm still in the field, is because there's always, the field is giving back to me as much as I'm giving to the field, I think. So I'm excited. But we
It's,
also talked about the career as an RVT.
yeah.
And that I have talked to people, I've interviewed people on this podcast who absolutely freaking love vascular. You know, if people do it, they love it. There's some people who just, that's all they do. They do it as a career. And there's other people kind of like OB, either you like it or you don't like it, right? But it's definitely worth getting some experience and understanding about it, because it just is a deeper understanding of the human body and how marvelous we are and how our bodies compensate and how they can revascularize and repair itself. And I think when I learned vascular, I really thought, wow, what a complex system we are, right? We're really quite the phenomena as a human, right? That we can develop the way that we do and communicate and provide blood flow to the area, right? So, what would you say to someone who um, might not be too excited about learning vascular?
Oh, wow. You know, I don't think it's a horrible thing for folks that are out there doing ultrasound to get experience in a lot of the different areas of ultrasound. But I think vascular, it is um, a specialty within ultrasound that is incredibly rewarding, and it's mentally stimulating. It and I've done all elements of ultrasound, and I can tell you it still gets me excited. Even though I'm using some of the stuff that I used 40 years ago, I still, the new stuff, it gets me excited, and I like the challenge of it because it can be challenging because it's um, sometimes we are faced with um, sometimes the anatomy is hard to see or whatever. But with the new techniques and the new stuff that we see going on out there, it really keeps you thinking. And I think that's what happens to us here in the vascular lab. I mean, we get some younger folks that come in, but then we get some folks that have been doing ultrasound for a period of time. May work in a hospital for 10, 15 years. And then they really want to get into a specialty where they can kind of settle in and really focus in on doing some things that are challenging but yet rewarding. And I think it's the reward element. Um, someone told me that if it was easy, anybody could do it. And I think vascular is one of those specialties where it really, I think if folks get into it and like it, they're going to love it and spend the rest of their career in it. So I would encourage anybody to consider doing some vascular. It may not be your thing, but I think that you might surprise yourself. You might find that it is a rewarding thing.
Well, it is a basis for understanding almost every other modality, I think, right? So once you understand the vascular system and how it works, you apply it to every other modality. You use it in general for liver transplants, renal transplants, right? You use it in cardiovascular for the heart and the carotids, and it just gives you a broader understanding. It did for me anyway, a broader understanding of how things really work on a base level. And then zoom in. Now, I meant to ask you, I'm going to circle around back to a topic that we talked to earlier because I forgot to ask a question. So we have recently been exploring 3D color Have you had that in your lab? How do you use that and apply it? And has that helped in your
We've been using it some with aorta evaluations. We have the 3D probes. We are using one of the 3D probes. Some of the doctors like it for access for like venous procedures. They use the biplane element. I'm not sure that it's fully there to the degree because I do echo as well, and I know I use 3D a lot there for like 3D EFs for the heart, and I think that's using some artificial intelligence, and I mean it is here too, and a lot of that is about what's useful to us and what's going to be useful for the patient, and I have a couple of people that swear by the 3D evaluations for the aorta in terms of getting the most accurate measurement of an aneurysm. And so I think I think it will evolve a little bit more and maybe be better. I think it works good right now. It's just like the 3D in the echo world. I think it worked good in the beginning, and I think it's a lot better right now. So I think we're going to see more improvement with that. And I think it's gotten to the point where it's trusted and used. It's kind of the standard in echo. And I think we may see that happen with some of the aorta evaluations. And that's what we do a lot here. We do a lot of workups for EVARs, the endovascular aortic repair. We put stents in the aortas to repair them now. They rarely do, but they do still open repairs, but for the most part, they stent them. And, I think what I could foresee us doing a little bit more of is using ultrasound enhancement agent.
is what? I'm sorry, I'm having trouble hearing you.
Ultrasound enhancement agent, contrast.
Oh, okay.
It's been used a lot in the cardiac world, but I think we could see more evolution into the vascular world. It's a little bit more off-label, but I could foresee us doing that and using it to look for leaks for stents and in certain applications in vascular. Contrast, I think, would be, and I think it will evolve as well to be used a little bit more. We're looking into doing that here. So
yeah, we didn't even talk about contrast agents or So
yeah. Oh, I love
that was a big game changer in cardiac, right? Years and years ago. Yeah.
Well, yeah, I mean, it was years ago. I mean, of course, the agitated saline is kind of the beginning stages of that. And then there have been at least 3 or 4 other types of agents.
Right. Bubble study. Yeah.
Like DEFINITY has been used a lot, and it's great. In the echo world, it really helps with endocardial border evaluation. But for us, I mean, I think we had a case a little while ago where we had something going on in a carotid. And gosh, I wish I had some DEFINITY. I'd try to see that a little bit better. And I think I think ultrasound contrast or ultrasound enhancement agent is what the proper term is these days. Is going to have a role potentially in vascular here, and maybe an increasing role. So I think that could be exciting.
Yeah. Yeah, that will be exciting. Well, regardless to say again, to reemphasize, how this field just keeps giving and developing and getting better. And I don't think AI is going to ever replace our jobs.
No.
I think it will enhance our jobs, and
Absolutely.
we will be required to do more and more. But
well, that's why you can't really train on the job anymore like I did. Everybody, I think, I think folks are having a hard enough time getting what they need under their belt with the conventional programs.
Right.
And ultrasound, it's expanded. And that's what I say to students today, because when I start telling my stories about did carotids without color and blah, 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 you can they roll their eyes and they say, you look in 10 to 15 years from now, from where you are right now, I said, who knows what you'll be telling. You'll probably be telling your student that, oh, I remember back when I had a cable that connected the transducer to the machine.
Right.
And you don't know and where
Right.
this could go. And so I think that's what's really cool. What's around the next corner?
Yeah. Yeah. I'm speechless with the limb flow procedure. I am so super excited about that and the future of that for so many patients. Um, wow. I'm super excited to hopefully read some articles on that in the future because that is really going to change the world of vascular, I believe.
Right. Well, the scope of vascular, it has a lot of branches, and you get into big vascular labs, and we do a ton of venous procedures as well, and that has changed a lot. I mean, there was a time they were using a laser in treating insufficiency for
Right.
patients that were symptomatic with varicosities, and now we're using three different approaches. Actually, here we're using four, but primarily, we got RFA, radiofrequency ablations,
Right.
venous seal, which is what's been around, and surgical glue, and it works great. And folks have been responding wonderfully, as well as Varithena. So that's just another element to all of this. I mean, if you were to come into the field of vascular, I mean, I don't think it's boring.
No,
I
not
think there's a
anymore,
good answer.
right? Not
I'm
anymore
not
at
getting
all.
bored, right?
Yeah. And if you are in a rural hospital, these things are really, you're doing a little bit of everything, right? And then you get a lot of really unusual things that you really have to kind of think outside of the box on sometimes. And so I think it's good to be exposed to a lot of different vascular procedures and different things to do. And
Yeah, I still have done a little bit of work in a rural hospital, part of our system, and yeah, I mean, I was at one of those hospitals one day, and they said, "Oh, I had a venous ablation up in Vermont, and I just needed to get a post procedure evaluation." It's kind of nice that you know what's going on with that so that you can do
yeah,
the exam. And so, yeah, to your point, I think though that out in the rural communities, I am so impressed with the folks out there that have the knowledge to be able to do a little bit of a lot, and they are, the expectations they got to do some vascular. They got some. There are some rural hospitals where people are doing some vascular. They're doing some general. They're doing some OB. They're doing cardiac even, and my hats are off to them. And I know some of them that do it, and they are just they're really good. And so yeah, no, it's necessary because it brings what's needed out into communities where people would probably otherwise not want to make the trip into a larger center or get the
right.
specialty care. So I think that's a wonderful element to what happens in healthcare.
Absolutely. Well, thank you, Dewey, for sharing your expertise and what's old and what's new in vascular. It's exciting to hear other modalities. Being able to, when you're in one modality, you don't hear that there's advances in other modalities either. So it's nice to know that not only does it bring advances in your specific area, but other areas as well. So in general, ultrasound is taking huge leaps forward in every modality, right? And how does 3D affect vascular versus echo versus OB versus, general? Um, it's a wonderful thing to explore and experiment with, right? And to learn more about. So if you're on the fence about vascular, I encourage you to explore it and get involved with it to understand it because it's the basics for almost everything that you do in ultrasound. So, and then you can specialize and really get very specific with a lot of these higher technique vascular procedures that Dewey has mentioned, and you do see life changing events happen before your eyes, and it does give you a feeling of contribution to the human race, right? When you can be a part of somebody's better health, right?
Absolutely.
So thank you for your contribution and for sharing these new and old ideas with us. And we hope to hear from you again soon.
Thank you. Appreciate you having me on.
Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend and remember to keep your frequency high.